Hello everybody, this is Dr. Ashur. Today we are going to start a new series of videos about management of inflammatory bowel disease. In part 1 we will discuss the inflammatory bowel disease itself, what it is, the different types of inflammatory bowel disease, pathogenesis, clinical symptoms and extraintestinal manifestations, and then classification of drugs used for IBD, inflammatory bowel disease. We will just discuss today, we'll have enough time to discuss only the first class of these drugs, which is mesalamine-based therapy. Okay, let's start. Okay. So it is, the IBD is chronic, idiopathic, the cause is not well known, inflammatory disorder of the GIT. Okay. It comprises two distinct disorders, okay? The ulcerative colitis and Crohn's disease, okay? Just a quick look here, okay? Look at ulcerative colitis, okay? It is usually, it appears in the rectum, okay? And sigmoid colon, okay? Whereas Crohn's disease can involve any part in the small intestine, but mostly in the ileocecal junction. Okay, this region is the most commonly affected by Crohn's disease, but again it can cause inflammation in every part on the GIT. Okay, so as a quick comparison between these two diseases, so Crohn's disease versus ulcerative colitis. Symptoms are kind of similar, but it will be more severe in Crohn's disease, of course. Let me start here with the ulcerative colitis: abdominal pain, rectal bleeding, bloody diarrhea. Whereas in Crohn's disease, abdominal pain, diarrhea, nausea, vomiting, weight loss. It could also lead to fistula. It could also lead to obstruction. It could also lead to perforation, as you will see. Okay. So, ulcerative colitis starts at the rectum, as we say, okay? So, and then progress proximally, okay? So, in the distal colon and the rectum, okay? So, rectum, and then you go up, so rectum here, okay? And then you go up to the sigmoid colon. This is the most commonly affected area, okay? But it can go more, but if it goes, it will go continuously, no patches. Okay, look here, it's here discontinuous on Crohn's, but here it goes continuously, okay, as you will see later, okay. It affects only the colon, okay. If you forget, remember it's ulcerative colitis. Colitis means inflammation in the colon, right? So this will make it easy for you, okay, and ulcerative means formation of ulcer. For Crohn's disease, it has a discontinuous pattern, as you see here. Okay, so it goes here, so inflammation, no inflammation, inflammation, no inflammation. This continuous pattern throughout the GIT is called skip lesion. Okay, so it's kind of inflammation, no inflammation, inflammation, no inflammation. This is characteristic for Crohn's disease. Can affect the entire GIT. Okay, so. But as we said, mostly common affect the ileocecal area or ileocecal junction. Okay. Ulcerative colitis, number 1, is characterized by confluent mucosal inflammation, mostly superficial, okay, in the colon, starting at the anus, so going from way distal, right, and extending proximally for a variable extent, okay, such as proctitis. So this is the shortest one. Left-sided colitis going on the descending colon, or pancolitis when it involves all the colon, okay? Whereas Crohn's disease is characterized by transmural inflammation that affect all the layers of the GIT, okay, of the colon or of the small intestine, wherever it goes, all the layer of this tissue will be affected. But most commonly the areas close to the ileocecal valve. Okay, the inflammation of Crohn's disease is not necessarily generalized, frequently leaving skip areas or skip lesions. Okay, as we said in the previous figure, of relative normal mucosa. Okay, so normal mucosa inflammation. Normal mucosa, inflammation. The transmural nature of the inflammation of Crohn's disease may lead to fibrosis, strictures, or alternatively fistula. Okay, it causes significant GI symptoms, diarrhea, abdominal pain, bleeding, anemia, and weight loss. Extra-intestinal manifestation of IBD, this arises from the fact that there are inflammatory mediators are formed in the inflammatory body. The word inflammatory. Okay, there are cytokines such as IL-1, TNF-alpha, leukotrienes. All these inflammatory mediators are there, so they can go in the bloodstream. That's why they can affect, anywhere in the body, such as musculoskeletal system can cause arthritis, or ankylosing spondylitis, or fusion of the spine. Hepatobiliary system, it can cause sclerosing cholangitis, inflammation of the common bile duct. Ocular system, or uveitis, inflammation of uvea or iritis, corneal ulcers, retinal vascular disease, or dermatologic system can cause bioderma, gangrenosum, okay, where there is a condition that can lead to necrosis of the tissues and can lead to ulceration, and erythema nodosum, inflammatory disorder affecting subcutaneous fat. Classes of drugs used for IBD. Okay, the class number 1 is the one what we are going to talk about today, which is the mesalamine-based therapy. Then glucocorticoids, immunosuppressive agents, anti-TNF alpha therapy, and then antibiotics and probiotics. We are going to discuss the first class today only. So mesalamine. Okay, mesalamine, synonym, 5-amino salicylic acid, 5-ASA, okay, 5-ASA, amino salicylic acid. This is the first line therapy for mild to moderate ulcerative colitis, even though it's very, has been discovered a long time ago, but it's still used as first line therapy for moderate ulcerative colitis. However, there is an issue of this amino salicylic acid, or 5-ASA, which is that it's rapidly absorbed from the small intestine. So now it's going to the bloodstream where it's not needed. We need it in the GIT. We need it for ulcerative colitis, as we said. We need it to go to the colon, okay, or at least to the distal small intestine. But this does not happen with the unformulated, just the 5-amino salicylic acid, the mesalamine itself. It does not go beyond that. So it does not reach the small distal, small bowel, or colon in appreciable quantities. So there is a number of formulations have been designed to deliver 5-ASA to various distal segments of the small bowel or colon, including sulfasalazine. It's the oldest one, the prototype drug of first generation mesalamine compounds, and then the second generation mesalamine compounds, which include all-salazine, balsalazine, pentasa, asacol. Please notice the sal is there, okay, sal, okay, or asa, okay, so amino salicylic acid, or at least a sal, okay. All of these are distinctive for mesalamine. Okay, as we said, it's a prototype of this class, consists of asa is linked to sulfapyridine. Sulfapyridine is sulfonamide, okay, but here it's not used for its antibacterial action. It's bound to 5-ASA by this azo bond. Why? Because this will allow ASA to stay in the small intestine until it reaches to the colon, where it will be degraded. This bond, azo bond, will be degraded or cleaved by the azoreductase or azidoreductase enzyme that can release the active 5-ASA. Okay, so now it's kind of a carrier molecule, just carrier. Okay, so now I need this ASA to go to the colon, then I use sulfasalazine. This is a prototype drug. Okay, it represents one of the first examples of an oral drug that's delivered effectively to the distal GIT. We said it's used for ulcerative colitis, and said ulcerative colitis mostly affect the rectum and sigmoid colon. So way until the end, right? So it needs to go there, right? So that's why you use sulfapyridine with it. to allow for ASA through the azo bond to reach to this distal GIT. 5-ASA is now regarded as the therapeutic moiety. It's the therapeutic moiety, the 5-ASA, not sulfapyridine. Actually, sulfapyridine is responsible for many of the side effects of sulfasalazine. The second generation mesalamine compounds. Now we have good thing and bad thing in the sulfasalazine. We achieved, okay, the targeting. We achieved the carrier, okay, or carrying this 5-ASA until the distal GIT. We succeeded in that. But we have the sulfapyridine, which is responsible for many of the side effects. That's why the second generation mesalamine compounds came to deal with this issue. Okay, number one, to remove the sulfapyridine and replace it by other compounds that are less toxic or has less side effect or no side effects. In addition, as you will see in pentasa, can we cover most of the small intestine along with the the colon? Okay, we'll see. So several second generation compounds, ASA compounds, have been developed. Okay, are divided into two groups: prodrugs such as ulsalazine, okay, and palsalazine. Coated drugs include pentasa, asacol. Let us discuss these in details. Okay, so prodrugs, okay, contain the same azo bond. They are similar to sulfasalazine, but just we replace the sulfapyridine by either another 5-ASA, so 5-ASA, 5-ASA. Look here, okay, this is the ulsalazine. This is 5-ASA, and this is 5-ASA, 5-aminosalicylic acid. Okay, this is okay. 1, 2, 3, 4, 5. 5-amino salicylic. This is salicylic acid, or this is sodium salicylate. 5-ASA, and these are the same thing. Copy. So 5-ASA, 5-ASA. So okay, this is called ulsalazine as a mnemonic. Okay, I hope this helps. Consider it ulsalazine. All sal. Okay, everything is sal. We have sal here. We have sal here. Okay, 5. Okay, sal. 5-aminosalicylic acid. 5-aminosalicylic acid. This I hope this makes it easy for you to remember, because we have other drugs that we're going to talk about. Okay, of course, sulfasalazine is this is the 5-ASA. Okay, the normal, but it's bound to sulfapyridine. This is the sulfapyridine moiety that we don't need. The second prodrug is palsalazine. This is the 5-ASA is still there, but it's connected also by azo bond to just an inert compound. Okay, an inert compound. Whether this, all of them will go to the colon, where they will be cleaved. The azo bond will be cleaved by the bacterial azo reductase. Bacterial azo reductase. Okay, we will reduce the azo bond. Okay, to release this 5-aminosalicylic acid, 5-ASA, also called mesalamine. I hope you know it's clear so far. Okay, so this is the prodrugs. What's remaining? Yes, coated drugs. Okay, we have two types of coated drugs. Okay, either delayed release formulation, pentasa, delayed release formulation in which 5-ASA is released. Throw out, please remember this. Throw out the small intestine. This is the only one we are going to see today that can cover most of the small intestine along with the colon. Okay, this pentasa is just microspheres, okay, within an ethyl cellulose semi-permeable membrane. Okay, so this is a way that our colleagues in the pharmaceutics department, they can prepare this to allow for delay release of the drug all over the GIT, generally speaking, starting from almost the jejunum, ileum, and then the whole colon. Okay, and also in addition to the rectum, anus, everything. So, and then the second one is a pH-sensitive coating. So this is kind of an enteric coating. It's in which 5-ASA is released in the terminal ileum, so way on the end of the small intestine and colon. So this one is kind of enteric coating and it's also pH sensitive. Okay, there is enteric coating that allow to only open when the pH is equal to or more than 7. So it will wait, you know, in the beginning I mean in the stomach the pH is 1 to 2. Then in the duodenum the pH will start to get little more. But in the terminal ileum, okay, the pH will be definitely 7 or more. Okay, so here this coating will release the active compound, which is 5-ASA. Okay, the examples are Asacol and Lialda. Asacol and Lialda. 5-ASA may be delivered in high concentration to the rectum and sigmoid colon. This is, you'll take it, through the anal canal. Okay, so either through enema, okay, and the name is Rowassa, or by suppositories, Canasa. Suppository will go a little bit, shorter. Rowassa will go for enema will go little higher, maybe up to the sigmoid colon. So let us see here, graphically. Okay, so number 1, Pentasa. Okay, Pentasa, delayed release capsule. This is from type 2 or second generation. Okay, second generation, which is the coated drugs. Okay, so it's Pentasa. So this one we said it is microspheres within ethyl cellulose, okay, semi-permeable membrane. So it will allow the delayed release of the Pentasa of the 5-ASA. You see, starting from jejunum. So count, please. Jejunum, ileum, proximal colon, distal colon, rectum. Okay, so 1, 2, 3, 5, right? 1, 3, 4, 5. So penta, right? Okay, mono, di, tri, tetra, penta, right? So 5, 1, 2, 3, 4, 5. Easy. So I hope this mnemonic will make it easy for you to remember Pentasa. We cover all of these 5 regions, okay, and this is unique among the mesalamine-based therapies. Second one is the Asacol and Lialda. Please remember these names are very important, okay. Again, we said this is pH dependent. It releases when the pH is equal to or more than 7. And they start from terminal ileum, and also they cover the same areas as all other formulations cover the oral formulation. Then sulfasalazine, only the colon along with the rectum. All-salazine, balsalazide, all of them are similar, by the way, you remember, right? The only difference is what drug or what's the partner that's bound to 5-ASA through the azo bond. Here is sulfapyridine. It is another 5-ASA. Here is inner compound, okay? Okay, then the Rowassa, okay, which is an enema. Okay, so this allow you to give high dose of the drug, okay, through the enema, or and also through the suppositories through Canasa. The name, these are brand name, Canasa, Rowassa, okay? These are the sites of release of 5-ASA in the GIT. Okay, what's the mechanism of action of mesalamine-based therapy? Generally speaking, the actual mechanism is not well known, but the potential modes of action may include inhibition or production of these inflammatory mediators, interleukin-1, TNF-alpha, tumor necrosis alpha, tumor necrosis factor alpha, inhibition of NF-kappa, which is transcription factor pivotal to the production of inflammatory mediators. So many inflammatory mediators, their release is dependent on NF-kappa. Inhibition of lipoxygenase pathway. Lipoxygenase, if you remember, arachidonic acid, there is a COX and there is a LOX, right? COX produce the prostaglandin, thromboxane, and prostacyclin. LOX produce, leukotrienes, interleukins, okay? And the leukotrienes themselves are inflammatory mediators, okay? Also scavenging free radicals and oxidants. All of these free radicals can cause cell damage. But this is scavenging. These are the mechanism of the mesalamine. Inhibition of cellular function of mucosal lymphocytes and macrophages, some little immune suppressant effect, which also will help in dealing with this disease. Although the mesalamine is salicylate, it's 5-amino salicylic acid. So people will say, oh, so the effect inhibits, now we have inflammatory bowel disease. So now, okay, we know now it's salicylic acid. Just just whatever we learn about NSAIDs, we can just apply here. No, please, okay. This different, it does not inhibit COX, okay, but or the therapeutic effect does not depend on the inhibition of COX, okay. Even, okay, the traditional non-steroidal anti-inflammatory drugs, okay, may exacerbate IBD. So I'm almost contraindicated to use traditional non-steroidal anti-inflammatory drugs, and even selective COX-2 inhibitors such as celecoxib, okay, are contraindicated with people with IBD. Okay. Side effects, okay, generally speaking, sulfasalazine will be the one which has more side effects, okay, occurs in 10% to 45% of patients with ulcerative colitis, and related mostly to the sulfa, the sulfapyridine part that's connected through the azo bond to 5-asa, okay. So some side effects are just dose related. The name itself, dose related. If you minimize the dose or take them after meal, this will minimize the side effects. Okay. Allergic reactions are mostly also related to the sulfa moiety, such as rash, fever, hepatitis, pneumonitis, hemolytic anemia, bone marrow suppression. Again, related also to the sulfapyridine inhibition of intestinal folate absorption. You know, sulfapyridine and all sulfa drugs inhibit folic acid synthesis, so they can inhibit intestinal folate absorption. Okay, therefore you give, okay, along with the sulfasalazine, you give the folic acid supplement. The newer mesalamine formulations, such as Pentasa, Sacol, Lialda, and all of these have similar therapeutic efficacy in ulcerative colitis, but they are generally well tolerated, and side effects are relatively infrequent and minor. Maybe some headache, dyspepsia, skin rash, okay, may occur. Okay, oral, the uses, okay. Oral sulfasalazine is effective in patients with mild to moderate active ulcerative colitis. We said it's the first drug of choice, okay, with response rate in ranging about 80%. Regardless of the disease severity, the drugs play a useful role in preventing relapse. Please remember this when we talk about the glucocorticoids, okay, because they have an issue with maintaining their remission, okay, but these guys can prevent relapse once the remission has been achieved. Remission is the period of relief from the disease, okay, because this kind of chronic disease, okay, so they will induce remission, so the patient will feel some relief from the inflammatory bowel disease, okay. The mesalamine can help this relief to start to maintain for a long time. Initial dose of sulfasalazine is 500 milligram twice a day, increase gradually to 4 grams a day. Usually the lower the dose, the better, okay, if you can, okay. So just take it as much as you can control the disease, okay, to avoid side effects. Divide four divided doses with food. As we said there are dose related side effect could be minimized by decreasing the dose or taking them with food. Dose as high as 60 grams per day could be used, but the instance of side effects will increase. Okay, the second generation mesalamine lack these dose-related side effects, so you can go, okay, with more dose, okay. So usual doses to treat active disease are 800 milligram 3 times a day for Asacol, and 1 gram 4 times a day with Pentasa, with much lower side effects. Okay, and you can use lower doses for maintenance. In Crohn's disease, sulfasalazine is less effective. Crohn's disease is more tremendous. Okay, so also these drugs are more effective in ulcerative colitis, but whenever you use them for Crohn's disease, sulfasalazine is less effective. Asacol and Pentasa, they require higher doses than those used for ulcerative colitis. Okay. Ulcerazine, balsalazine, sulfasalazine, okay, ulcerazine, balsalazide, I'm sorry, sulfasalazine, all of them, they only open in the colon, okay? They don't have significant effect in a small bowel Crohn's disease, okay? So if it is small bowel, so I need something to open up there, right, in the small intestine. So these drugs that contain this azo bond, these drugs that contain the azo bond, okay, that opens only in the colon to release 5-asa, they are not effective in small intestine Crohn's disease. Okay, that's it for now. Thank you for your attention, and I'll see you soon with the second video where we'll discuss the remaining 4 classes of IBD therapies. Until then, I wish you have a wonderful day. See you. Bye.